So our next speaker is Dr. Jessica Crystal. Once you had your melanoma diagnosed and it's not a melanoma that is fit for Mohs surgery, then patients have to have their surgery. And there has been a lot of development in that area. Some of these more advanced melanomas now are treated with systemic therapy before they get their treatment. And Dr. Crystal is going to tell us who are those patients and how do we decide who needs systemic treatment before surgery. Dr. Crystal.
Great. Thanks, Jose. I'm Jessica Crystal. Nice to meet everyone. Thank you for joining us today, and thank you for the opportunity to present. Forgive my voice a little bit. I have a little bit of a cold. Today, we're going to be discussing, as Dr. Lutsky mentioned, surgical management in melanoma. When is systemic therapy needed beforehand? Hold on, let me just move this. Okay, sorry, my Zoom. I have nothing to disclose. Today, we'll be talking a little background about melanoma, some of the treatment plans, surgery, and systemic therapy, and our conclusions. So as far as melanoma goes, and I'm sure we'll touch on some of these points multiple times today, but they're important. Melanoma most commonly arises in the skin, cells called melanocytes, which produce pigment called melanin, and you can see that on the right. Although melanoma often starts in the skin cells, as shown, sometimes it can exist in non-sun-exposed areas, including in the eyes, mouth, or under the nails, which Dr. Lutsky is going to go into a little more later, those mucosal melanomas. And the non-sun exposed ones. Additionally, malignant melanoma represents only about 1% of all skin cancers, but there's a lot of attention to it because most of the deaths are a result of this type of cancer. In 2025, over 100,000 patients were diagnosed with malignant melanoma. Over 100,000 were diagnosed with melanoma in situ or pre-cancer, and about roughly 8,430 patients died from melanoma in the U.S. Unfortunately, this is likely an underestimate of the true annual incidence, as many of these superficial and in situ melanomas are not reported. So sometimes patients are in the outpatient office and things are quote unquote burned off, or just a little small shave excision, and are not reported to the American Cancer Society when they're accumulating their data and their statistics for the year. We do find that there's increased incidence of new invasive melanomas over time, with over 46% new invasive diagnoses in the past 15 years. The median age of diagnosis is 59. When I'm examining a patient myself, Dr. Tang, or any of the panelists on here, we look for pigmented lesions that have the ABCDEs of melanoma. So we're looking for asymmetric borders. We're looking for the borders to be uneven. We're looking at more than one color, or the color of the lesion, looking if it's darker or not. We're looking at the diameter or the size, typically greater than 6 millimeters. And we're looking at evolution. Does it change in size, shape, color, or another trait? Typically, one of the key points I note in my patients is change, evolution. If they're seeing a change in any of their pigmented lesions, that's most concerning to me. When we're looking at risk factors for melanoma, there's personal or hereditary factors and then environmental factors. And these are different factors that we have that make you at elevated risk for melanoma. This includes male sex, age greater than 50, your skin type, frequent burning, multiple moles, immunosuppression, family history, including inherited genetic mutations, and then, of course, sun exposure, particularly tanning. When we think about melanoma, we have to think about how to stage it. And the staging helps guide us to tell you what your prognosis is. When we're looking at the stage of melanoma, the early stages are confined to the epidermis, or stage 0, or melanoma in situ. When it starts to progress further in the depth fashion, that's one of the key factors when we're staging melanoma we look at is the depth. We start getting into the more invasive components, and that's typically stage 1 and 2 are characterized by the depth of the melanoma seen under the microscope, in addition to some ulceration. As melanoma progresses, it has a tendency to then spread to the lymph nodes, which then makes it stage 3. The other component of stage 3 is other lymphatic involvement, like in something called in-transit disease. In-transit disease is lymphatic deposits of tumors that are not actually in the regional nodal basin. For the future components of this talk, I'm going to be referring heavily to the stage 3 population, as these are the ones that the neoadjuvant immunotherapy is best tested in. Subsequently, if melanoma spreads beyond the in-transit disease or beyond the lymph nodes, it's stage 4 disease. And stage 4 disease constitutes as melanoma spreading elsewhere in the body, including the brain, lung, bones, liver, intestines, and elsewhere. As mentioned, the staging of the disease guides us to what we can predict as the survival. And unfortunately, as melanoma progresses and spreads to the regional nodal basins and beyond, unfortunately, the 5-year survival rate declines. So patients who present with localized melanoma, stages 0, 1, and 2, have an excellent prognosis with a 98.4% 5-year survival rate. Unfortunately, that drops to 63.6% when patients have regional nodal disease or in-transit disease, and unfortunately to 22.5% for the metastatic melanoma patients. We'll discuss shortly the treatment for these different types of tumors. However, it's important to consider when we're considering which type of treatment, we take into account these survival rates in how to guide our patients to get excellent cancer control while also trying to limit the morbidity of the different treatments. Now, as far as treatments go, the main workhorse for melanoma is surgery, as Dr. Tang already alluded to. Now, Dr. Tang and I both work very closely when melanomas are just between typically stage 0 to 1, depending, as she already mentioned, on the location and the depth of the melanoma. When the melanoma starts to get a little bit deeper or in other sites of the body that are no longer suitable for Mohs surgery, the patient gets referred to me, and we perform one of the standard components of melanoma surgery, which is wide local excision. Wide local excision includes a removal of the skin and the underlying subcutaneous tissue down to what we call the fascia or the covering of the muscle. This allows for removal of all the tissue, what we believe should be all the tissue in the adjacent subcutaneous lymphatics to really clear out the area of the melanoma. The other component of this is helping us find a true diagnostic component of this surgery, as many patients present to us with just a biopsy. And by removing this space, we're able to get a better sense at the true depth of melanoma. Now, as far as the margins go, the margins are the space around the biopsy site, which we need to remove. And as you can see on the right, depending on the depth of melanoma, determines how wide of a margin we have to take circumferentially. So if it's pre-cancer, we only have to take 0.5 to 1 centimeter. If it's less than 1 millimeter in depth, we take 1 centimeter. And then beyond that, the 1 to 2 centimeters or 1 to 2 millimeter in depth, and then greater than 2 millimeters, you're in the 2 centimeter margin. Of note, these margins are currently being evaluated in a large randomized control trial called MELMAR, which recently closed to accrual and was available here at Sylvester Cancer Center, where we're trying to readdress the role of margins in these patients. Of note, we will potentially adjust those margins based upon location, as previously described by Dr. Tang. Now, another important component of our surgical approach to melanoma is evaluating the regional nodal basin. And there's 2 different types of surgery to evaluate the lymph nodes, and it depends on whether or not there's clinically node-positive disease. Clinically node-positive disease is disease that has cancer in it when the patient is encountered. So you either identify it on physical exam, or it's identified on imaging. And typically a needle biopsy or an excisional biopsy is performed to confirm tissue diagnosis or spread of melanoma. If this is involved, it then becomes stage 3 disease. However, some patients present to us with what we call clinically occult disease, meaning that we can't find any lymph node disease on physical exam ahead of surgery. However, there's microscopic disease present nonetheless. So typically in this situation, when we evaluate a patient, if we only identify a biopsy site change and we don't identify any abnormal lymph nodes ahead of surgery on physical exam or selective imaging, not every patient needs imaging, but selectively we'll use it, We'll then recommend for the patient something called a sentinel lymph node biopsy, which is injecting a radioactive tracer and blue dye around the primary tumor to identify the first lymph nodes where the cancer typically spread. We'll typically perform this in patients that have either ulcerated melanomas or once they start to get greater than 0.8 millimeters. Sorry about that. If there's any uncertainty in the actual depth, or if the risk of melanoma involvement in the sentinel lymph nodes is greater than 10%. Of note, sometimes Castle Biosciences has a genomic expression profiling test can be used to evaluate sentinel lymph node biopsy, but as a group, we're not yet all in agreement to use it. Now, that's when we have clinically node negative disease. And that sentinel lymph node biopsy is performed to identify little microscopic disease to tell us whether or not a patient's stage 3. For clinically node positive patients, there's a different type of lymph node surgery we perform called a lymph node dissection or lymphadenectomy. And this surgery removes all the lymph nodes in a region. There's two different ways to think about this. One is a completion lymph node dissection, which is surgery performed after the sentinel lymph node biopsy to remove the remaining lymph nodes in the basin. So this happens when a patient has a sentinel lymph node biopsy. The melanoma is identified under the microscope in some of these lymph nodes that are removed. And then we deem that select patients may need this additional surgery to remove the additional lymph nodes. This was very much common practice in years in the past. However, a very large randomized trial was performed looking at the role of this completion lymph node dissection. And in fact, they found in majority of the patients, even with multiple poor prognostic factors, completion lymph node dissection was no longer necessary. So it's important to think about completion lymph node dissection in patients, but it's a tool that we use less frequently than in the past. Now, a similar surgery that's performed is a similar concept, but a slightly different name, is called therapeutic lymph node dissection. This is the same exact procedure as a completion lymph node dissection in the regards that we're removing all the regional lymph nodes in a basin. However, there was no sentinel lymph node performed initially because patients who receive a therapeutic lymph node dissection actually had a clinically node positive disease a priori, meaning when the surgeon or the clinical team evaluated the patient, they identified a lymph node with disease prior to that surgery. And therefore, at the time of surgery, they removed all the lymph nodes in that lymph node basin. The reason I brought up all these different surgical techniques are the different types of surgeries are used at different points in our subsequent trials looking at neoadjuvant immunotherapy. So that brings me to my next point and the next treatment that we have for melanoma, and that's immunotherapy. Immunotherapy is a type of medication that uses the body's immune system to attack cancer. There's different types of immunotherapies that are used. One of the initial ones studied was CTLA-4 inhibitors, or ipilimumab. And you could see on the chart how ipilimumab acts to bind to a CTLA-4 on a T cell and allows the immune system to fight its cancer. There's another type of immunotherapy called checkpoint inhibitors, which also work to release the body's immune system to allow the T cells that are already in your body to attack tumor cells and kill the cells. There's different types of checkpoint inhibitors, some that block PD-1 or PD-L1, and a newer type called LAG-3. The initial studies that were testing immunotherapy occurred in patients with metastatic disease, as many of our cancer systemic therapy studies go. And these initial studies showed a significant survival benefit. So once the medical community identified a survival benefit in immunotherapy, which was incredibly important because, as you recall, when patients hit the stage 4, unfortunately progress to the stage 4 amount of disease, their prognosis and 5-year survival drops dramatically. So the medical community then subsequently said, listen, if our immunotherapy is working so well in the metastatic setting, who else can we use that in? And this led to subsequent studies looking at adjuvant immunotherapy for patients with stage 3 disease. So here are 3 of the key trials that were used to identify using immunotherapy in what we call the adjuvant setting, meaning the patient got their surgery up front. So they typically got a wide local excision and either a sentinel lymph node biopsy, which ended up being positive, or a lymph node dissection because they had a positive lymph node up front. And they then treated the patient with various types of immunotherapy. EORTC 18071 looked at ipilimumab, Checkmate 238 looked at nivolumab versus ipilimumab, and then Keynote 054 looked at pembrolizumab. The key point here is all these studies had a positive benefit in some form of survival, may it be overall survival, recurrence-free survival, or distant metastasis survival for patients, and proved that immunotherapy should be a key component of treatment in patients with stage 3 disease. Of note, not there's no free lunch in the world, and certainly not in medicine. And the reason why they don't just give this immunotherapy to everyone is because immunotherapy does have its own side effects and its own toxicities, in specifically immune-related toxicities, including problems with the endocrine system, for instance, the adrenal, the pituitary, can cause diabetes, thyroid, it can cause colitis, it can cause pneumonitis, encephalitis, etc. So when they were looking at these studies, they only wanted to, some of the rationale for using it was who's going to benefit from this the most, whose risk-benefit ratio is going to be sufficient enough, there's going to be enough benefit that it's worthwhile to risk these side effects. So now that they saw those in the metastatic setting having a positive response and the adjuvant setting having a positive response, we started to look at who else can we help? And so people started looking at what we call neoadjuvant immunotherapy, which is immunotherapy up front followed by surgery. And in principle, the reasoning or the rationale why we considered using it is because we felt that if the primary tumor was present, there was a larger source of tumor antigens for those immune cells to recognize. So when the checkpoint inhibitor came in or the immunotherapy came in and unleashed the immune cells that are already there to attack the tumor, there was more tumor present for those immune cells to attack. In addition, one of the added benefits of using neoadjuvant immunotherapy is if we saw how the patient was responding to the treatment. So we see that this is a immunotherapy sensitive tumor or not, we're then able to guide the patient to what the next steps are. So should we be continuing the same immunotherapy? Should we switch? Fortunately, recently, we've had a handful of studies looking at a bunch of different immunotherapy regimens. Should we change the immunotherapy regimen, or should we go ahead and just perform surgery? And of note, each of those decisions are individualized on each patient's amount of disease. So one of the very first studies looking at neoadjuvant immunotherapy was the SWOG S1801. This was a phase 2 randomized controlled trial evaluating patients with stage 3B to 4C melanoma that were amenable to surgical resection. There were 2 groups the patients were randomized in. The first group received 3 doses of neoadjuvant pembrolizumab, followed by surgery, followed by 15 doses of adjuvant pembrolizumab. Of note, typically these patients would have received some form of a wide local excision and typically a therapeutic lymph node dissection at the time, as they were presenting with clinically node-positive disease. The other arm was surgery followed by 1 year of adjuvant pembrolizumab. Treatment was continued until disease recurrence or unacceptable toxic effects developed. The neoadjuvant arm had a significantly longer event-free survival, 72% versus 49%, as you can see on the survival curve on the right. So in addition, 28 of 132 patients receiving the neoadjuvant immunotherapy had a complete pathologic response. That means just those 3 cycles of immunotherapy completely killed all the tumor. Of note, 1 patient had complete imaging response, however, declined surgery. So we don't know if they truly had a path complete response, but after 31 months of follow-up, no disease was detected. Shortly after, or around the time that SWOG 1801 came up, an additional study from the multiple groups in Europe came out called OpACIN-neo, where they were looking at a slightly different regimens compared to just the single agent like SWOG 1801. So in OpACIN-neo, they looked at stage 3 melanoma patients, so lymph node disease and in-transit disease, and randomized patients to one of 3 different neoadjuvant dosing arms combining ipilimumab and nivolumab. They evaluated for both toxicity and efficacy. The arm that was the most benefit with the least toxicity was group B, 2 cycles of ipi plus 1 milligram per kilogram and nivolumab, 3 milligrams per kilogram once every 3 weeks. And this was very well tolerated with a very high pathologic complete response rate of 77%. Of note, this was used in a subsequent trial that I'm going to be talking about momentarily. One of the important findings from this study is that pathologic response to neoadjuvant therapy appeared to result in a durable and reliable surrogate for recurrence-free survival and overall survival. That's important because we sometimes don't know how to assess a response, and waiting for an overall survival benefit to determine whether or not a patient's responding to a treatment is a very long time to wait if you don't know what's happening, and it's difficult to guide the patient based upon that. So as mentioned, the subsequent study to OpACIN-neo was the PRADO trial, which used that ipi-nivo combination and then started to adjust what we do in the surgical realm of things. So I previously mentioned to you for stage 3 disease, we were typically removing the primary site, the wide local excision, followed by the lymph node dissection. The group in the PRADO trial said, hey, if we're getting such dramatic pathologic complete responses and partial responses, why are we doing this big lymph node surgery that has multiple different side effects? So when I counsel patients on lymph node dissections, I warn them of those side effects, which include injury to major blood vessels. We're removing the lymphatic bearing tissue along major blood vessels in the extremities or in the neck. We are potentially can cause injury to major nerves that allow you to do many of the things you like to do. For instance, moving your arms and legs the way you like. It can result in numbness and pain. And in addition, significant lymphedema or significant swelling of the arm that sometimes is unreversible. So this study says, if we are getting such a dramatic response with immunotherapy alone, stimulated by the tumor being present up front, why are we bothering with this big surgery? So what they did is they removed the index lymph node, which is the largest lymph node metastasis at baseline, and then they removed it and looked at it under the microscope and determined what the response was, whether it was a major pathologic response, a partial response, or a non-response. Based upon that, they decided the subsequent treatments, whether they do that therapeutic lymph node dissection, the removal of all the lymph-bearing tissue, and then whether or not they surveilled those patients, or whether or not they give subsequent adjuvant immunotherapy. In this study, they showed that this selective approach to management of the path response was feasible, with a partial response rate of 72%. Therapeutic lymph node dissection was omitted in almost all the patients with a major pathologic response, and there was excellent relapse-free survival of 93 and 98%, and distant metastasis-free survival of 93 and 98% in the patients with the major pathologic response, dropped down to the mid-60s with the partial response, and 70% in patients with no response. An additional trial looking at immunotherapy up front looked at combo agent as well, but was also looking at de-escalating some of our treatment. But instead of de-escalating surgery, it was looking at de-escalating the adjuvant immunotherapy arm. So the NADINA trial looked at macroscopic stage 3 melanoma using 2 cycles of neoadjuvant ipilimumab plus nivolumab, and looked at patients who then got surgery versus patients who got surgery first, followed by adjuvant nivolumab. At the median follow-up of 9.9 months, the estimated 12-month event-free survival was 83.7% in the neoadjuvant arm and 57.2% in the adjuvant group, as you can see on the right. In the neoadjuvant group, 59% of the patients had a major pathologic response, compared to the 8% and 26% with a partial and non-response. Ultimately, the 12-month recurrence-free survival was 95.1% in the neoadjuvant arm, who had a major path response, and 57% in the non-response. These significant findings led to the conclusion that neoadjuvant immunotherapy is an excellent approach to patients with stage 3 disease. Unfortunately, these studies that I've previously mentioned are not yet powered to de-escalate surgery yet, but it gives us ideas for the future of how to guide our trials. So in conclusion, while melanoma can be an aggressive disease, we currently have many promising options for treatment. Using a combination of surgery and systemic therapy, particularly immunotherapy, can result in excellent control of disease. Future studies need to be performed to optimize the use of these modalities. Thank you.